I thought I'll do my best to sort of give you a little bit of an inside view as to what it is like in the public health system and what the public health system is meant to do. And I feel like, we've all been exposed over the past 2 years or 3 years to terms and ideas and concepts and groups and committees that we might never have heard of before, that now are kind of common lexicon because everybody is getting a little bit of an insider view already in the public health system. So I'll sort of give you a little bit more information about those. So I'm hoping that everybody can see my screen. And as I said, today I'm going to do, I guess, a little bit of an expose of the federal, provincial, and territorial structures. It's not going to be by any means complete. I'm going to give you the spoiler right now, which is it's complicated. But we can talk a little bit more about that perhaps in the Q&A. So we'll talk a little bit about the Canadian public health system as it's structured, and hopefully we'll have some fun along the way. I don't have any of the usual disclosures in this particular presentation, but I will say that I love public health practice. It is probably my first love. Some of you heard the story as you were coming in about how I came into public health, and I in part blame my parents and then also my younger sister, who's a family physician, but finished medical school ahead of me as I was finishing graduate school. And she was the one who put the idea that public health might be the right fit for me into my brain. I have to admit, I was offended at the time. I remember saying something like, "What do you mean? I want to be a real doctor. How could you say such a thing? Who are those people?" Because we don't have a training program here at Dal where I did my MD. And so I had no idea what public health was actually about. And she sort of had a very patient sigh. And then she said, "Go look at the websites for these programs and tell me that that is not you." And I saw these websites where, as a physician, I could have a career in tackling health inequities and in dealing with social determinants of health and in prevention, like actual upstream prevention. And I was like, why didn't anybody tell me? I had no idea you could do this as a career in medicine. And I was hooked at that point. So I'm going to start by telling you a little bit about, sort of what public health is here to do. And then I think we're going to end with, quite frankly, a question around whether or not we're actually well prepared to do it in Canada today. And so this is the latest report from Dr. Theresa Tam, the Chief Public Health Officer of Canada. And it is her post-pandemic, if we can say post-pandemic. I don't think we really can. We're still in the middle of it. But it is her look forward from the pandemic into what Canada's public health system needs to be based on the lessons learned from COVID-19. I was a reviewer on this report, and what I had hoped we would see is, as the report sort of describes, a real vision for a strong public health system based in principles of public health practice and public health sciences that I'll describe in a little while. But the question of what is the Canadian public health system can be a little bit elusive. And I think if any of you have seen or read Dr. Tam's report, you'll see that elusiveness kind of reflected in the report. And so the origins of public health in Canada, certainly in the 1800s, were actually around largely communicable disease control. And those controls were legislative, and they were engineering controls, building code controls, those types of things, largely due to the circumstances of immigration into this part of the world at that time. And so you had large numbers of people migrating from, in particular, Europe into what was, considered to be North America at the time, or Turtle Island. And so concerns rising about those people bringing with them communicable diseases that were rampant in Europe at the time. And so those early efforts were really about reducing that threat on the shores of North America. That's what public health started as, but certainly it's evolved from then. And what we'll talk about today is what is it meant to be today based on that start. In 1998, the US Institute of Medicine actually did their own report on the future of public health, and that's what's on the right-hand side of your screen. And this report is still today considered to be a seminal description of public health programs around the world. It was a beautiful description of what all the functions that public health is meant to perform, not only the communicable disease prevention function, and how public health needs to be structured, particularly at the local level, at the municipal level, even the neighborhood level, in order to be able to carry out those functions. There were some really good descriptions of public health in that, and I just want to bring your attention to a few things. First of all, I would point out that when I talk about the public health system, I do want to be clear, I'm not talking about the publicly funded healthcare system. And I do hear that a lot from folks, and even at the beginning of the pandemic, when folks talked about public health, there was some confusion, I think, in the public around, is that the publicly funded healthcare system? Is that Medicare? Is that what we're talking about? The public health system actually performs a completely different function than that acute care system. And the function that public health system performs is probably best summarized by these two definitions. The original is from Winslow in 1920, but the modern version of it is from this is the Canadian version, is Canadian Public Health Association, just from earlier this year. And they describe, basically, Winslow described it's the science of art of preventing disease, prolonging life, and promoting physical health and efficiency through organized community efforts. So looking beyond that start in the 1800s around communicable diseases to other diseases that were prevalent by the early 1900s, and the need for prevention, and particularly a focus on physical health and community efforts. And so the modern version is not dissimilar to that. It actually says that public health is the organized efforts of society to keep people healthy and to prevent injury and illness and premature death. And further describes public health as a combination of programs, services, and policies that protect and promote the health of all populations, all Canadian populations. So what does that really mean? Is the question, right? And how do you actually define that in ways that give shape to the public health systems that we see in action today, for example, around COVID-19? Honestly, I would say that even amongst public health practitioners, there is some debate around this, around how you define public health. And so depending on where you sit and what you have access to, you may well define the public health system differently even than the Canadian Public Health Association does, or you might sort of agree with the Canadian Public Health Association definition, but also add an interpretation of it that is consistent with where you sit in the system, in part because the Canadian public health system is quite complicated. And so, as I said, we'll talk about that in a moment. But this is the way I describe public health when I'm talking to my family, including, for example, my sister, who's a family physician, and my parents, who know what she does, but took them a little longer to figure out what I do. To my accountant, this is how I explain what I do. And I did have the benefit, as you heard in the intro, of training both in family medicine and as a public health specialist when I was at McMaster University doing my residency training. And so I've practiced in both areas. I stopped practicing family medicine in 2011. And the way I describe public health now is in comparison to that. And so what I understand now is that as a family physician, I might have held a patient population of 1,500 patients, maybe 2,500 patients, depending on how busy the clinic was. And I'm not going to see them all every year necessarily even, but I will see each of them periodically when there is a need. And that roughly translates to about 20 or 30 patients that I would see in a day. And in that day, I might not know what's going to come in the door next. So I might start my day with a well baby visit, and I might move on to removing somebody's sutures. And after that, I might get to a place where I'm counseling somebody for a mental health condition. And then after that, I might be doing a prescription renewal for chronic disease. But by the end of the day, I've seen 20 or 30 people, and I have a sense of what they came in for that was a problem, what I needed to do to make the problem better. And if I didn't know what to do, then I knew that I could send that patient to a specialist who would develop a care plan with them after seeing them, and then send the patient back to me, and we would manage from there. And so I always knew in family medicine that yes, it was going to be a complicated day. Yes, there was going to be a lot of diversity, but at the end of the day, I knew the limits of my practice. And I knew that if I reached the limits of my practice, there was a specialist community out there that would help me support the patient to get to the next level of health. So I was always interested in anything that those individuals came in with in the run of that day. As a public health physician, I am not interested in anything that makes any individual sick. Full stop. But I am interested in anything that might make them sick in groups, or is making them sick in groups, and anything that has the potential to make them sick. And I want you to think about that potential for just a moment. That potential is huge. So the potential to make populations sick en masse exists in our drinking water supply if we don't manage that appropriately. It exists in our environment more broadly, including in the foods that we eat, and the agriculture industry that supports the foods that we eat if we don't manage that properly. It exists in our broader environment in terms of the goods that we consume, the toxicity associated with some of those goods, particularly the more highly manufactured they are, the release of chemicals into the environment from a number of factors, climate change. These all are threats to the population in groups, large groups in some cases. That's the work of public health, is to stand in front of that potential to make people sick in groups so that it never materializes. So I thought family medicine was big. And I was grateful to know the boundaries of my practice and be able to send the patient to a specialist once I reached that boundary. To this day, I can't tell you what the boundary of public health practice is. Because as far as I can tell, almost anything can create a public health issue at any time. And quite frankly, if we reach the boundary, I can't tell you for sure what we do at that point, because you can't send the entire community to a specialist, right? What I do know is that it's probably for that reason that public health around the world is actually tied to government systems, be they municipal governments, provincial or state governments, or national or federal governments. Because when we reach that limit for an entire population, it's often only government that has the reach to be able to extend into communities and say, okay, what else could we do from a policy, legislation, built environment perspective that actually moves the threat away from this whole population and gets us back on the path to good health. And so I think in public health, when we reach our limits, that's who we reach to as our next partner, not a specialist, but actually government agencies to help us do that next level of work. And so this is what this means in practical terms. And I think back to when I started as a medical student at Dalhousie many, many years ago now. If you had asked me then if I ever had to know anything about the life cycle of a mosquito, I would have probably told you that was ridiculous. Why would I have to know that? I mean, that's entomology. Does that really have anything to do with medicine? Oh no, wait, that's actually malaria prevention, West Nile virus prevention, Zika virus prevention, right? Because if you can interfere with the mosquito so that it never acquires the communicable disease it's going to transmit to humans to begin with, then you prevent that disease occurring in humans, right? So that is communicable disease prevention. If you asked me if I had to know anything about the engineering of highways as a physician, I would have said, again, come on, don't be ridiculous. That's engineering. That's for them to do. Except that if you engineer the highways in such a way that you actually reduce the amount of kinetic energy that's transferred from a motor vehicle and its surroundings to the passengers at the time of impact during a motor vehicle incident, then you reduce the likelihood of those incidents ending up in emergency rooms. And so that is injury prevention. Similarly, if you asked me if I had to know anything about the construction of cities and how cities are built, city building as an idea, I would have said, what is that even? I have no idea what you're talking about. Well, it turns out it's related to city planning and architecture. And all of that is related to chronic disease prevention. If we actually build our communities in such a way that the health behaviors and the healthy environments are baked in, they are built in so that citizens don't even have to think about engaging those behaviors, then the outcomes practically create themselves. And so some of my favorite work as a public health physician has been with city planners, engineers, architects, doing that important city building work that we know actually creates cancer and chronic disease prevention targets. And again, if you'd asked me if I had to know anything about grade 12 graduation rates, I would have given you a blank stare, like, really, how is that related to health outcomes? Except that the most important of the determinants of health of all of them is graduating from grade 12 with high math skills and literacy skills in the language of your choice. And so you start to see how the complexity of public health is generated, and also the ways in which, when I say public health has no boundaries, I'm quite serious. Public health doesn't seem to have any boundaries, because all of these things contribute so tangibly to health outcomes from our perspective. So we have a name for that kind of work we do with those other sectors in order to get at that potential for diseases and that potential for prevention. We call it primordial prevention. And so if you're not familiar with the levels of prevention, let me just take you through that a little bit. So primordial prevention is represented in this slide on the left. And I always start by describing for folks primary prevention, which is what most people are oriented around. So this is the idea that primary prevention is the idea that there are risk factors for disease out there. If we can do something to prevent that risk factor from actually becoming disease in any individual, we should do that. And so this is often the work that your family physicians will do. For example, somebody has high blood pressure, we want to prevent that from becoming strokes down the road, or somebody has is a smoker, we want to prevent that from becoming lung disease or cancer or cardiovascular disease down the road. And so we want to do something to mitigate that risk factor so that it doesn't become disease. That's really important prevention work. Secondary prevention is too late, the disease has started, but it's early. And so if we can prevent the disease from getting worse and actually reverse the path of disease so that maybe the person actually has, achieves cure, that's where we need to intervene. And so our screening programs come in here, where we try and pick up disease as early as we can, because the possibility is there that we might be able to reverse the disease at that early stage. Tertiary prevention is too late. Disease is established. So now what we're looking to do is prevent the worst outcomes from that disease, prevent as much harm as possible from somebody having that disease. So that's what we normally orient around in the acute care system, in particular, that publicly funded healthcare system that I mentioned before. But in public health, we orient around this. If primary prevention is preventing disease from occurring when the risk factors are already there, primordial prevention is preventing the risk factors from ever existing. And I want you to just think about that for a moment. Preventing the risk factors from ever existing. So I say this to some audiences and they say, okay, come on, really, Gaynor? That's, that really sounds like kind of rainbows and pixie dust. But on the other hand, other folks will say, well, I can kind of see that. If you look at what public health has done, for example, around tobacco, now we've lost some of those gains in recent years, but up until the early 2000s, we were starting to see situations where generations of young people were actually growing up largely without any exposure to tobacco as a product, because we had removed it from their environments. And in doing that, we had decreased significantly the risk of tobacco ever becoming a risk factor for disease for all of those people. And so in order to do that, you use all the tools at your disposal, which include bans on advertising and legislation around sales and age limits around sales. And so it's for those reasons that public health is in relationship with those other sectors I mentioned, like education sectors and justice and employment sectors and transportation sectors and community design sectors. Depending on what risk factors we're trying to modify, we need all of those folks, because obviously those risk factors don't live inside the acute care health system. They live out in the broader systems of societal influence. And so there's a skill set that goes with being able to navigate that from a health perspective. And so as a physician, to be able to step into those places with confidence, there's a skill set that is needed. And so that's the skill set that, that public health holds that makes it very different from the acute care system. And so just as an example, and apologies, I can't quite figure out, I did at one point manage to get this bottom menu to go away, but I can't quite figure out how to do it now. In any case, maybe I'll move it up here for the time being. Just as an example, you will hear folks, including in public health, say things like poverty. We have to do something about poverty. It is such a major risk factor for poor health outcomes. That's absolutely true. But without the skills to navigate those broader societal systems of influence, those social determinants of health holding systems that are outside of the healthcare system, you will see healthcare practitioners and others start to flounder at that point. And so folks will want to do something. Often what we'll do is stand up a program. Somebody stand up a program somewhere. There must be a program we can put in place. It might be through the health system, maybe it's through community services, but we'll have a poverty prevention program, and that will help individuals come into some kind of supportive state where they may be able to mitigate the impacts of their poverty. The skills that we hold in public health when we do primordial prevention well are much deeper than that. It's not simply about slapping a program onto individual outcomes and hoping for the best. And bureaucracies love programs. So we're aware that because we sit so close to government, often that's the first thing that we're asked to do is put together a program. But if we're doing primordial prevention well, then actually we're applying a level of analysis that takes us into a deeper look at where the actual root causes of the problem are before we apply any solution, including a program. And so this method we call the 5 Whys in public health. Some of you will have seen this before. It's a method of serial inquiry into an outcome in order to expose sort of the earliest place where you could intervene in future to prevent that outcome from happening. And so this is from the Government of Canada website. This is the classic example. You'll hear public health doctors and practitioners all the time talk about Jason's broken leg as an example. Why is Jason in the hospital? Well, because he has a bad infection in his leg. Well, why does he have an infection? Because he got a cut on his leg and it got infected. But why does he have a cut on his leg? Well, because he was playing in the junkyard next to his apartment building and there was some sharp, jagged steel there that he fell on. Well, why was he playing in a junkyard? Because his neighborhood is kind of run down and a lot of kids play there and there's no one to supervise them. But why does he live in that neighborhood? Well, because his parents can't afford a nicer place. But why can't his parents afford a nicer place? Well, because his dad is unemployed and his mom is sick. But why is his dad unemployed? But why? And so you do this exercise, not for the purposes of sounding like a toddler or driving the people around you crazy, but actually for the purposes of figuring out where is the most effective intervention that we could level that actually would set the stage for Jason and everybody around him to have a better outcome here. And so we could treat Jason's infection and his leg would get better. Or we could have a conversation with community planners about whether or not the junkyard in his neighborhood needs to be there and whether it could be replaced by some green space or a playground. Right? We could have a conversation with the education system about dads like Jason's dad and whether or not there is a need for us to look at how we can make sure that more of them have access to the education they need to get the job that sets up the opportunity for the income to have a nicer place to live, right? And so that's the exercise, is to take it down to that level so you can see where's the broadest intervention you can apply. The first time I did this exercise, I think I was a second-year family medicine resident in Hamilton, Ontario. And the exercise was run by the family physician that I was working for, and he said, okay, let's try it. So you have a patient who is a Black woman from Central Africa, and she has HIV, and why does she have HIV? Discuss. And as a group of family medicine residents, we went through this exercise and eventually came out with an answer that was something like the impact of the Industrial Revolution in African nations, and the way that meant that men left their communities often to go to the cities to get work, and in the cities they might have been exposed to a number of things, including communicable diseases. And by the time we were done, as a group, we had this, what the heck are we supposed to do with that? You just said the answer was the Industrial Revolution. And so then you work it forward. Well, what is the thing that you can do something about in real time, in modern time, that might actually change the landscape for as many of these patients as possible? That's the idea behind this method of the 5 Whys. And so when we're dealing with questions like poverty, we use this all the time. And in the real world, it actually works. That public health method actually works. So this is an example from Kansas City, Missouri. This was the Robert Wood Johnson Foundation Culture of Health Prize winner in 2016. This story is still on the Robert Wood Johnson Foundation website. And I do encourage any of you who are interested to go and have a look at it. It's a beautiful story. And so the story starts by describing Dr. Rex Archer as the medical officer of health coming into Kansas City 17 years prior and looking around and asking some questions about, tell me about the 480,000 residents of Kansas City. And in that sort of search, going to the city's vital statistics, where he found that life expectancy for white residents of Kansas City, Missouri was 6.5 years longer than that of their Black neighbors. 6.5-year discrepancy in life expectancies. And so by applying that 5 why question over and over and over again, they began to identify the levers for the Black community, and especially Black men in Kansas City, that actually changed things, and they were able to reduce that life expectancy gap by something like 2 years in a 10 to 12-year period, something like that. So we say things like public health outcomes are intractable and we'll never see the results. That's not true. If you do this exercise well, you can actually see the results of it in real time, and certainly within a career. And so the methodology is a sound one and worked quite well. We've used it here in Nova Scotia. We had participation in this national study on street-involved youth. This was several years ago now, but when we did the study, the task was for us to recruit 180 street kids as the Halifax site, one of 7 sites across the country. This was not a difficult thing to do, by the way. Recruiting 180 street kids in Halifax, unique street kids in Halifax, is an easy thing to do. And so we recruited 180 kids, and then we got a blood draw from them and a urine sample from them, and then embarked on a qualitative interview, a 45-minute interview that was basically a 5 whys question. And you know, the entry for public health is always going to be around a health outcome for the most part. We could do this exercise with any outcome, education outcomes, justice outcomes, but we're public health, so we do it with health outcomes. So we do the blood draw, we do the urine sample, we're looking for bloodborne pathogens in these youth to suggest that they may be at higher risk or not. That's really the hypothesis that we're testing. But in the 45-minute qualitative interview, where we're asking sort of this serial why, in the Halifax sample, we had several youth point to the beginning of the end for them being when they were divorced from what was the only remaining stable adult system in their lives, the education system, as early as age 7. So these are kids who are being disciplined in school because of disruptive behavior. That disciplinary action led to them leaving school permanently, and there were no other adults around for them, as young as age 7. So outcome, HIV in young people. Initiator, possibly education system justice, or education system disciplinary processes. And so you take a simple entry, right, that outcome, and then you work it back, and you end up finding these answers in what we call wicked problems. So the way I define public health, you know, we've talked about a few definitions, but the way I sort of define public health, or sort of the summary of public health practice for me, is that it is the only branch of medical practice that is required to systematically identify and expose differences in health outcomes for the purposes of resolving them. And this includes communicable diseases, which is where we started, but all health outcomes. Public health has a responsibility to systematically identify them and then expose the differences between group A and group B, so that together we can do that 5 why exercise and start to resolve those differences, put in place meaningful solutions. And so I come back to that original definition from the Canadian Public Health Association around the organized efforts of society to keep people healthy, right? The thing is, society will often self-organize to resolve the issue. So the formal public health structures do need to be there, but they need to be there for when society isn't resolving the issue itself. And so this diagram was part of the discussion that I put forward when Dr. Tam was writing her report. And, you know, what I said was, there's a way in which public health issues in the sort of central blue box often are managed by the community at large before the formal public health system gets involved. And a few things can happen. In one scenario where the purple arrow goes, community actually figures out the solution, they implement the solution, and the issue goes away without public health ever having to do anything. This is often the case for community issues that public health never needs to intervene in. There's a second scenario, which is public health in the the blue circle on the left-hand side of the slide, might actually be the ones to identify the issue by way of their surveillance systems. But even then, they're going to get into a co-management issue relationship with communities, so they're never going to manage the issue alone. And so either the community comes up with a solution after public health has identified it, or together with public health, they come up with the solution. But either way, I do want to sort of leave you with the point that communities have to be involved in the generation of these solutions. And so that capacity to self-organize is something that we need to recognize in public health as we do that work that the CPHA definition defines. Public health is also defined by these 6 core functions that were first laid out by the Naylor report in 2003. And so you will remember, some of you will remember, this was the seminal report that came out on the state of the public health system in Canada after the SARS outbreak in 2003. And many provincial public health systems and the federal public health system, the Public Health Agency of Canada, was actually created as a result of this report from Dr. Naylor. And so he named 6 core functions of public health that public health systems in Canada must be oriented around. And so surveillance and population health assessment being, in my mind, sort of primary. That's the basis for our differentiation of health outcomes in one group versus another. Health promotion efforts, certainly around creating healthy conditions in communities to prevent disease. That goes hand in hand with our other prevention methods. Health protection is a very specific term. It actually means the legislated responsibilities of public health under public health legislation in every province and territory in Canada. And those legislated responsibilities include communicable diseases as well as environmental health hazards. So noxious cloud of gas floating over the city, public health is meant to have a response to that, in addition to the communicable disease responses that we've seen, for example, in COVID-19. And then, of course, emergency preparedness for circumstances like the noxious cloud of gas floating over the city towards a vulnerable human population, but also to threats like COVID-19, as we've seen. And so those 6 core functions of health also define, public health also define public health systems in Canada today. So that's the setup for, at least in theory and often in practice, how public health is meant to work. And now you're wondering, okay, but in real life, does this actually happen that often? And so I'm going to say it's something like it depends. And so to come back to that elephant, it depends, and it depends on where you sit in the public health system as to how this really works. And what that speaks to in particular is Canada's federated nature. We do have 13 provinces and territories, and jurisdictionally, each of those have a slightly different approach to how they meter out, for example, those 6 core functions of public health that Dr. Naylor described. So if you look at the Nova Scotia example, this is the description of public health on the Nova Scotia Health Authority webpage. So if you go to the Public Health tab in Nova Scotia Health Authority, you will see this. There is some reference to news and articles, pregnancy and parenting, public health in the community, infectious diseases and immunizations, and then there's a contact public health and then information for healthcare providers. But what you don't see is those 6 core functions, for example, from Dr. Naylor listed. They are listed in Nova Scotia practice in a different document that is buried on the provincial government website called the Nova Scotia Public Health Standards. And it's in those standards that you start to see a little bit more of what Dr. Naylor was talking about. So in a science and systems performance team, which Nova Scotia Health Authority has, would be where the surveillance and population health assessment functions rest. The healthy communities team is where a lot of the chronic disease prevention and injury prevention work might rest. The healthy development team similarly has a prevention and health promotion role. And then that health protection work done by a protecting health team. So those teams do exist. They're not named in the Nova Scotia Health Authority sort of page when you go to look for it. The work of those teams around the 6 core functions of public health are named in the standards document. That's not on the Nova Scotia Health Authority page. It's actually on the provincial government page for public health in Nova Scotia. And so if you go to the provincial government page in Nova Scotia, you see a slightly clearer picture, at least with respect to Dr. Naylor's description, where public health is defined as communicable disease prevention and control, environmental health, healthy communities, which again would be that chronic disease and injury prevention, healthy development, population health assessment and surveillance. So you start to see those core functions a little bit more clearly. Emergency preparedness isn't named here, but that is also a core piece of what exists in the provincial office. This would be the office that is run by Dr. Strang, and the office that I was deputy chief in. And so some coherence in that provincial one. This is an example from a local public health unit in Ontario. And so this is Halton Region. This is Oakville and Burlington area in Ontario, for those of you who know the region. And so here you see a variation on Dr. Naylor's 6 core functions to some degree. So you see health statistics, that's the surveillance and population health assessment. You see health equity, that's about social determinants of health, so that prevention work and health promotion work. You see specifically substance use and mental health as you see oral health as a focus, inspections, that gets at the environmental health and communicable disease work to some degree. And so it's a little bit of a variation, but more specifically targeted at particular health outcomes and particular health issues than, for example, the Nova Scotia Health Authority example. And again, on the Government of Ontario side, so this is from Public Health Ontario, which is a bit of an arm's length public health agency separate from the Ministry of Health and Long-Term Care in Ontario, which also has some public health responsibilities. But here again, at the provincial level, you see something that looks a little bit closer to Dr. Naylor's description. So they have emergency preparedness, environmental and occupational health, health promotion, infection prevention and control. And then on top of that, they have specifically immunization, specifically environmental and occupational health, and then antimicrobial stewardship and public health practice as areas. So again, a little bit of a variation, but you see something that looks a little familiar from Dr. Naylor's description. Here's the Manitoba example. So this is Manitoba Health. This is, I think, the provincial public health page. And so here you see, again, some semblance of what Dr. Naylor described. So environmental health, epidemiology and surveillance, communicable disease control, and then diseases and conditions list, which would include communicable diseases. So that's there. And at the Winnipeg region level, you see, again, it's a little faint, but you see again a list that looks not dissimilar to what we saw, for example, for Halton Region. So environmental health, communicable disease prevention and management, healthy built environment, that would be chronic disease and injury prevention work, healthy children and youth, healthy parenting, healthy sexuality, immunization, injury prevention, mental health, nutrition, physical activity, and then surveillance, tobacco reduction, and travel health and tuberculosis as a specific focus for Winnipeg Region. So when I say, do these descriptions, these definitions play out in real life in a way that you can see and touch and understand? And my answer is kind of, sorta. I think you start to see why I might say that, because it's not at all clear cut in the Canadian context. And in fact, in the international context, it's equally confusing. So this is the latest sort of description of public health from the UK, where Public Health England has been now divided into these 2 offices: the Office for Health Improvement and Disparities, which would be largely chronic disease and injury prevention and health promotion work, and then the UK Health Security Agency, which is where the communicable disease efforts in particular now rest in the UK. So they did have them integrated as one. They've actually now divided them into 2 separate government offices in the UK. And so public health structures around the world are not necessarily well set up to fulfill those core functions of public health that were described by Dr. Naylor. In Canada, not only do we have this, kind of woolly, sort of description of public health at local or provincial levels, at the federal level, we have a multitude of acts that actually speak to public health in one way, shape, or form. And we also had the Public Health Agency of Canada specifically, which I mentioned before and was created with Dr. Naylor's report in 2003. from where I have sat as a local medical officer of health and then as a deputy chief medical officer, I'm going to give this description of what the public health agency does from a practical perspective. It is by no means complete, and I think my colleagues from the public health agency would have much more to say about what public health does, but what Public Health Agency of Canada does. But in particular, with respect to, for example, COVID-19, this is the role that we have seen, which is that the Public Health Agency certainly has been intervening and coordinating intervention regarding COVID-19 in Canadian communities. It coordinates our National Micro Lab, which is our level 4 laboratory for sort of the most virulent and dangerous pathogens. And that lab is in Winnipeg, and so it reports through to the Public Health Agency of Canada. The Public Health Agency also coordinates what we call field epidemiology services. So these are the sort of field investigators that we might send into any part of Canada or any part of the world to investigate something that is emerging but unknown, like COVID-19. And in fact, our field epidemiologists would have been involved in the initial investigations of that to the extent that they could get access. Folks will remember during H1N1 that our field epidemiologists were actually deployed to Mexico when that outbreak was unfolding at that time, and the world was still wondering, what exactly is this? Is it influenza? It looks like influenza, but we're not sure. Canadian field epidemiologists were involved in that investigation at that time. And so the Public Health Agency has that role, and they will also intervene and coordinate intervention and prevention efforts. So they have a number of prevention programs that they run in cooperation with the provinces and territories and with local governments and local public health agencies with respect to a number of other threats: environmental health, contaminated products, chronic diseases. All of that programming actually has a home within the Public Health Agency, but it's less of a hands-on role for the Public Health Agency with those. It's more that they are supporting provinces and territories and local jurisdictions to deliver that work. As if that wasn't complicated enough, the Government of Canada describes the sort of responsibility for health as resting amongst 5 agencies, actually, that they call the health portfolio. So in addition to the Public Health Agency of Canada, you have Health Canada, which is in particular responsible for therapeutic products and sort of licensing of drugs, that type of thing. So we've seen their role in COVID-19 with respect to licensing, for example, of COVID-19 vaccines and treatments. The Canadian Food Inspection Agency is responsible for the safety and security of our food supply, including our agricultural supply. We have then 2 boards, basically: the Patented Medicine Prices Review Board, which is responsible for pricing of therapeutic agents in Canada, and then the Canadian Institutes of Health Research is named as the 5th partner in the health portfolio. And so you start to see the complicated nature of the Canadian public health system. If you ask somebody in the public health system in Canada, who is responsible for public health in Canada, give me the one place where I go to get all my public health answers, you can't. You have to, depending on the question, go to one of 5 agencies, and that's without talking about the agencies in between that are supporting public health practice, like the National Collaborating Centers for Public Health Practice. There are 6 of those across the country. Some of the provincial at arm's length agencies like Public Health Ontario, BC-CBC, INSPQ in Quebec, these are all important players in the public health system in Canada, but they're not easily defined when you go to look for a description of the public health system in Canada and how does it actually work. So there are some structures that try to put it together, try to make it work. One of those structures is Public Health Network Council. So this is the council of federal, provincial, and territorial deputy ministers of health. And they sit alongside the chief medical officers of health as, in theory, the governors of the public health system in Canada. The challenge with this particular model is this: local public health issues bubble up from local communities. They actually don't bubble up from federal or provincial or territorial policy tables. And so local public health units need to be in place in order to respond to those. And often by the time they have mounted a response to an issue, they can do all of that work without Public Health Network Council, of course, ever getting involved, because the issue, when it emerges, needs to be dealt with and resolved at that moment. You can't wait for a federal, provincial, territorial council of ministers and chief medical officers to come up with a solution. And so that local level of the system is really where a lot of the response lies. And so to that extent, the local level of the system is also networked, in particular through the Urban Public Health Network, which is the big city medical officers of health. So the 18 or 20 biggest cities in Canada, those medical officers of health meet on a regular basis to sort of trade ideas and discuss issues that are common in urban public health. There is an emerging rural public health network as well for public health physicians. So those types of networks do exist as well, similarly to support the public health labs across the provinces and territories. There's a network for those as well. So I'm going to end by giving you a few examples of sort of what this looks like in practice and some committees that you would have seen and sort of how they played into a few different scenarios, and then hopefully open the floor for questions. So just using COVID as the first example, I've described that the Public Health Agency would have been involved in the international surveillance and response efforts early on when the virus was first emerging in the world. And in that intelligence gathering effort, they would have eventually given a signal to Public Health Network Council that they needed to convene what they call their Special Advisory Committee. You will have heard about SAC on the news. This is the Chief Medical Officers of Health coming together with Theresa Tam and others to discuss the emerging issue and put in place plans to protect the Canadian public. And so that's kind of a routine mechanism that happens when a threat like COVID-19 emerges on the global scene. And so, SAC has a rotating chair, and the chief medical officers may bring their deputy chiefs and other technical advisors in order to deal with the issue. And so they, when I left the response, were meeting weekly, multiple times a week, and I suspect are still meeting several times a week as the response continues. So that's one example. In addition to SAC, our federal response documents also outline roles for committees called TAC, so a technical advisory committee. This often includes chief scientists, chief data technicians, deputy chief medical officers of health, and others who are not the chief medical officers of health, but maybe supporting that conversation by bringing forward technical information. There's a LAC, a logistics advisory committee, which is where procurement happens of equipment, for example, and vaccine supplies and that type of thing. There's a communications group, which is around media and public relations. And then there's a working group on remote and isolated communities. And so the structure is meant to mimic what we call an incident command system, which is commonly used in emergency response. And again, all of this is outlined in the Canadian Pandemic Influenza Plan. Having said that, what we also know, those of us who have done a few public health emergencies, is that real life never actually follows the plan. And so in addition to all of these groups, you do regularly see a number of other agencies weighing into a response. The National Advisory Committee on Immunizations is an example. In Canada, we have the Association of Medical Microbiology and Infectious Disease. We have a vaccine working group that is chaired by the federal government and co-chaired by the provinces and territories. These groups all also are part of what supports a response like the COVID-19 response. But in general, I would say we see a proliferation of substructures that are not anticipated in the pandemic influenza plan every single time we have an emergency. And so I do, when I'm teaching emergency preparedness, what I say is just remember, real life doesn't follow the plan. To give you an example, I was a resident in Ontario when 9/11 happened and public health agencies were being asked to prepare response plans for anthrax and smallpox and other things that were considered agents of bioterror. And we already had pandemic influenza plans, and then SARS hit. And we threw all of that planning out and started over because SARS didn't look like any of those things. And so it wasn't the written plan that was important. It was the relationships we had built in the planning process that allowed us to quickly navigate to who needs to be part of the response to this, what structures roughly need to support the response, and that's how we put that together. And so that's not uncommon during an emergency, and we saw that during COVID-19 as well. Here's another example. This is from our Foodborne Illness Outbreak Protocol. Again, another national protocol, this time centering around foodborne illnesses, so Salmonella, E. coli, those types of things. And that means that there's a heavy emphasis on the role of the Canadian Food Inspection Agency as the coordinator of that, not the Public Health Agency of Canada necessarily, although the Public Health Agency of Canada, Health Canada, and CFIA will often work together to control a response to something like that. So again, a different set of structures to deal with that, that type of threat. The opioid crisis is another one where the Public Health Agency of Canada may have had less of a frontline role because it's the provinces and territories in particular that are doing the work of, and local public health units that are doing the work of managing the crisis. So as cases of overdose come up, they need to be responded to immediately in those local jurisdictions. And so a lot of the central work is there. And it means the Public Health Agency then is in a support role to that local and provincial and territorial work. Where they have a big role at the federal level is in managing the big levers of prevention, so that monitoring and regulation of supply that might be contaminated. And this means they have a role in coordinating with other federal agencies like Canada Border Services, the RCMP, and others who may be in that monitoring of the drug supply space. And then finally, the Public Health Agency has regional offices that provide grants and program support to local public health units in particular. So at the municipal or community level, those regional offices will also support some national collaboration activities, you know, from coast to coast, and national projects like the street involved youth survey that I mentioned earlier. And so as a federal agency, they're involved in that support as well. The point I want to leave you with here is that although I've described sort of the broad structure of public health, the core work actually is at that local level where those day-to-day responses to all kinds of threats to the public are occurring. And so as I look at Dr. Tam's report, and if any of you engage with the report, I would be certainly interested to hear from you as to sort of your take on it. My hope would be that just like the American report did in 1998, in Canada, we will come to a place where our vision of public health includes a strong local public health system that is ready and activated to respond to those threats as they emerge, knowing that they will have the support of the provincial, territorial, and federal structures that are there as well. But that local system needs to be there and needs to be defined again in a way that has us be clear that public health may be needed to respond and is there on standby and ready to do all the things that I talked about if needed, but also that local communities may be able to do that work fine on their own, and that's entirely okay, and public health can be a support to that as well. So I'll leave you with this question, you know, around, you know, who should be involved, who is involved in the formal and informal public health system in Canada. I think this is something that Dr. Tam's report is trying to wrestle with. And I think really that was all I wanted to offer you by way of some insights tonight. So with that, I will thank you. I will stop sharing and happy to see all of your faces for questions.